So you mentioned something really, really controversial, by the way. Not controversial, but I think as a style of a practice. So talk to the audience. In your own case, you have a STEMI patient, comes in, say, enter STEMI. What's your step-by-step approach to that STEMI from access to closure? A simple way, how you do a STEMI case, a traditional STEMI case.
Sure. My own bias, #radial first, right? Radial access heparin anticoagulation, pre-treatment with Cagrelor as the P2Y12 inhibitor, in addition to aspirin. I'm a big believer in shooting the non-infarct artery, or the supposed non-infarct artery first, right? And then shooting the infarct artery, and then, of course, taking the appropriate guide catheter that fits, putting down a non-hydrophilic wire, presuming that you're wiring through thrombus and can't see distal to it. You're less likely to dissect when wiring blindly if you choose a non-hydrophilic wire. And there, I'm a big believer in taking a small balloon. I'll say 2.5/15 is usually my go-to balloon, unless it's a really distal event, and then you can go smaller. But take a 2.5/15 balloon, inflate at the point of occlusion, and then take a better angiogram and see what you're up against, right? Do you need to wire a side branch to protect it before you shift a bunch more thrombus down it? Maybe that's a good idea. Do you have a high thrombus burden, and is thrombectomy needed? And from there, you can move forward. I image intracoronary imaging 100% of cases, so I would do intravascular ultrasound. Preferentially, I like to co-register with the Philips systems we have, and then select a stent after you've completely prepped the vessel, and deploy the stent, image again, post-dilate as needed, and then retreat.
Yeah, and then thrombectomy only if it's super high thrombus burden or as a rescue.
Thrombectomy for high thrombus. So in my practice, and I think I can speak for my partners in this, thrombectomy in high thrombus burden and as a rescue, that is, I've ballooned, I still haven't, at least gotten TIMI 2 flow to the distal vessel. What can I do to improve that?
Yeah, so it's great. I think so. One of my colleagues and my partners in the same practice here graduated from Bay State. So this is exactly how he does, and I completely do something different. I'm a thrombectomy first. If there's any occlusion 100% or I see a thrombus, I go with thrombectomy. I put a 30-second, sit there, then pull it out. It helped me figure out the extent of the occlusion, because very commonly where the occlusion is and where the plaque rupture is, completely different places. The thrombectomy, you go in proximal and there's nothing there all the way mid-RCA or mid-LAD where the plaque rupture is. But that is, again, not by guidelines, that's preference. If my wire have a flow, I would not do it. I think what you mentioned, I think is extremely important. And I think that's something many of us can utilize, but we don't utilize correctly, is the intravascular ultrasound. I think it's extremely important. Sometimes you see a lot of thrombus burden there that may make you do different technique, either by vasodilators, pre-stenting, or thrombectomy. I think it's really a style. The biggest reason I see, or the most important reason that I see people in general want to do a low inflation balloon, in addition to figure out what's going on distal, which I think is a very reasonable and valid reason, is door to balloon. And I think that's a misconception that door to device equal door to balloon, which is the right thing. I think people worried about doing a thrombectomy and not ballooning. Have you noticed, that's a completely different topic, but I think it's important as we talk about STEMI. Do you think that the intention of door to balloon came from a good place, but are you seeing it in a practical way might be slightly harmful in terms of rushing things or access bleed or things like that? What's your take on that one?
It's a great point. So when door to balloon and Mission Lifeline and the AHA's endeavor came out, it really obviously came from a good place, trying to develop rapid systems of care, but it did create a quality metric which doesn't exactly correlate to outcomes. That is, faster is better, but nothing magic happens at 90 minutes, right? There's nothing. It's not like there's an inflection point in the graph and outcomes get asymptotically worse at 90 minutes. 90 minutes is a convenient number, right? It's a round number. You're 100% right. It's door to device. It's not door to balloon, right? Thrombectomy counts, right? So, it's not, it doesn't have to be a balloon. That being said, if you're using thrombectomy, and I'm not a a judge here, but my bias is that that's routine use of thrombectomy, right? That's the thing that gets the class 3 indication, right? If you're thrombectomizing every case, you might be doing it routinely. That is what it is. You also, if you have thrombectomy, you may save yourself some no reflow phenomenon. We don't have great data there, but I think it's intuitive that the more thrombus you leave, the more thrombus you treat with balloon, the more thrombus you shift downstream as opposed to removing from the body, the more no reflow you're going to get. And then you're going to be stuck at the end of the procedure with a suboptimal angiographic result. And, that can lead to stent thrombosis and whatnot. Just a longer time in the cath lab, flushing the coronary with adenosine or nitroprusside or epinephrine, trying to achieve an angiographic result that's better.
I know that your institution was part of the Impella study for STEMI, placing a stem of Impella, waiting for 30 minutes or so, and then intervention. Yeah, and I'm not sure you can share more details, but have you noticed that as a routine practice, putting an Impella first, are you having less no reflow in those patients?
No. So, I think our practice now is not a long unload period. We generally follow the practice from the National Cardiogenic Shock Initiative that used to be the Detroit Cardiogenic Shock Initiative, right? So if patients have either a sustained blood pressure less than 90 millimeters of mercury systolic or require pressors to achieve that 90 millimeters of mercury and an LVEDP of 15 or greater, in the setting of acute MI, we consider that a cardiogenic shock, and we put the Impella in first, and then from there, go ahead and do the PCI. And generally, we use a companion sheath single access approach from the femoral at that point. But I don't know that I can say that at least anecdotally, I haven't observed any difference in no reflow rates in kind of those sick patients with or without the Impella. I would say that there's one piece of it that we don't potentially think about that often, and that's just the amount of time that antithrombotic agents are working, right? If you're using an Impella before you do the coronary, you've had your P2Y12 agent, your aspirin, and your heparin going for a bunch longer before you start doing anything, and that may be beneficial. On the theme of no reflow, we joke in our cath lab that if you want no reflow to get better, adenosine is okay, nitroprusside's pretty good, and epinephrine's great. Not that one drug is more effective than the other, but the nurses are much more adept and used to preparing adenosine. They'll get it ready really fast. But if you ask them for epi, it'll take them 10, 15 minutes to get that ready for you, during which time the patient will have reperfused because they've been sitting in the, P2I12, the heparin, the 2B3A, whatever you've given.
I 100% agree. I think the routine use of thrombectomy for every single case is wrong. But I think we have cases where thrombus burden is high.